Right. Welcome everybody to the University of New Mexico Department of Psychiatry Grand Rounds. Today is one of our education Grand Rounds where we focus on some topics that we need to talk about every year because of credentialing issues, and we need to because they are critically important among some of the most important issues, not just for our trainees, but for all of us. We are very fortunate to have two real experts with us today, here to talk to us about these two issues. So I'm going to go ahead and introduce them, and then they will take it away. So first, we'll hear from Dr. Kristina Sowar, who is an associate professor in our department and the program director for the Child and Adolescent Psychiatry Fellowship. She's also the director of wellness initiatives for GME here at UNM, which makes her particularly qualified to talk to us about wellness today. Dr. Sowar was born and raised in Colorado and completed her undergraduate degree in medical school at the University of Colorado. She did her internship in family medicine in Santa Rosa, California, before we convinced her to come to UNM for her psychiatry residency and child psychiatry fellowship. And I remember those conversations very well. Clinically, her primary focus areas are care for individuals with eating disorders, emergency child psychiatry, and also ECT. She has a strong passion for education and promoting well-being amongst physicians, and in working towards integrating life and work with her young children and family. So we will hear from Dr. Sowar first, and and after that, we will hear from Dr. David Earl, who will talk to us about sleep and understanding the importance and mechanisms of sleep. And I'll tell you about Dr. Earl first so that I can disappear and we can all listen together to the two of them. Dr. Earl initially came to New Mexico in 2008 to work as a pharmacist for the Indian Health Service in Shiprock. After completion of a one-year pharmacy practice residency, he continued to work in Shiprock until he started medical school here at UNM in 2012. After graduating from medical school in 2016, he stayed here at UNM to complete his psychiatry residency, which he finished in 2020, and then completed a one-year fellowship in sleep medicine before returning to our department this summer. Dr. Earl's professional interests include informatics, quality improvement, and the overlap of sleep medicine and psychiatry. I asked Dr. Sowar and Dr. Earl if they would please talk to us about these two really, really important topics, and they agreed. So thank you, Dr. Sowar. Thank you, Dr. Earl, and I will hand the baton to you, Kristina.
Awesome. Thank you so much, Dr. Katzman. I appreciate the introduction. Thank you for inviting us. And yeah, it's great to co-present with Dr. Earl. This is a really nice opportunity. So I'll go ahead and jump in. Dr. Earl and I are going to divide the time relatively and then make sure to leave some space, hopefully 10 minutes or so at the end for questions and answers. So yeah, and again, thank you all for joining. I know sometimes wellness and well-being related topics is something that, people just have like mixed feelings about the formal didactics on, but the goal today is really to anchor into, again, like Dr. Katzman said, why we really think and have evidence about why it's important to be focusing on this and think about applications to our own lives. So let me go ahead and share. Please, at any point, feel free to chat if you have feedback, or certainly if there's any issues with my audio or Zoom. And then again, we'll kind of save more of the discussion towards the end. So let me go ahead and play this. Okay, so this is the title for Dr. Earl and I. The objectives today, the first couple I'll cover. So exploring why prioritization on well-being is important for healthcare providers in terms of quality of life, sustainability in medicine, and for our patients, for patient care and relationships. And then we'll talk about some strategies for personal resiliency, including some that maybe aren't ones that we commonly think about. And then Dr. Earl will focus more on the latter points with his lecture on sleep. Okay, I don't have any relevant financial disclosures to this content. And as Dr. Katzman mentioned, so I'm grateful to have a role in addition to the work in our department with the Office of Professional Wellbeing. So many of you may have heard about it, seen emails, or been in talks. So the Office of Professional Wellbeing is School of Medicine funded. The chief wellness officer is Dr. Liz Lawrence, who's had a passion for wellness for a long time and was able to get this up and moving and continue to grow the office, and is very nationally involved. And we have a team that's comprised of people who do more programming and initiative directorship, and then clinical care as well. And so I think it's really awesome, really exciting that, as you'll see here, we have multiple people from our department who are part of the Office of Professional Wellbeing. So the top row are the folks who do the clinical care. So Dr. Koyer, Dr. Ezechuku, they are our clinical psychologists who provide a tremendous amount of clinical care for individuals. And Dr. Dunn is our psychiatrist through the office. And then the bottom row here, I'm on the corner there, but Dr. Magdaleno, who's in the Department of Pediatrics, works on faculty initiatives. And Dr. Phillips, who you only recognize as well, is an anesthesiologist who does a lot of work with our medical students. And then we have some great administrative assistants, and it's just really a nice team. So I just wanted to make sure to recognize the team effort and also everyone in our department who's involved. So also to frame the start of this talk, that some of the research that I'll share or data is specific to physicians, but really conceptualizing this conversation in terms of healthcare professionals, medical professionals, and that I think we're really fortunate to be in such an integrated and multidisciplinary department where we have, psychiatrists, psychologists, and then certainly working with us clinically, people in other realms of nursing, pharmacy, various forms of therapy. So just that, this talk really is intended to be applicable across disciplines, recognizing as well that there are some components that are more specific to us in the individual realms. Okay. So wellness is a topic that's often referred to and not always very clearly defined. We come to associate certain definitions or concepts with it, but I wanted to share a little bit of formality here. For those of you that are interested, Stanford has a great center. It's called the Stanford Well MD program, and they have a lot of educational content. I just did a course this summer that was great about wellness directorship or initiatives, but they also have other content in terms of resiliency and self-compassion, various things like that. And they do quite a bit of research there. So these next couple slides, the content derives from some of the research that they've done looking at wellness amongst healthcare professionals. And one paper recently, which was really investigating what is the definition of wellness, or when we look at data on measuring well-being in our healthcare professionals, what are we specifically paying attention to? So the proposed definition here, just to give you a second to digest, around that wellness can be considered our quality of life, which includes the absence of ill-being and the presence of positive physical, mental, social, and integrated well-being experiences in connection with activities and environments that allow us to develop our full potentials. So that has a lot of depth to it, but I hope is one direction we can be looking towards this. And sometimes when we talk about wellness, or when it's been studied, people look at specific outcomes like burnout measures, mental health, depression, or measures of stress or distress. But there are these additional domains as well: our physical health, how much sleep we're getting, our work-rest balance, our social life, the quality of our relationships, and how well we're able to integrate life in terms of work, things outside of medicine, our sense of meaning, and how we're thriving. And so, this is an area, I think, of continued growth and hopefully clarity on the consensus of what wellness really means. So this is my graphic version of incorporating some of the components of wellness that I just want to make sure we're thinking about. So not only physical health and self-care that are listed here, but additional layers around inclusive environments, psychological safety that we feel, the quality of our relationships and our ability to find sustainability in this practice, as well as connection to the bigger concepts of like meaning that we derive from our work. And to talk a little bit about why wellness. So beyond just the thought that, wellness is good for everyone, right? No matter what your occupation or where you're spending your time, that really trying to have some notion of wellness and trying to improve our well-being is important. But we know that a focus on this for healthcare professionals can be additionally preventative in keeping people in better spaces, hopefully preventing things like burnout, and then also healing for people that have, found themselves in circumstances or situations where they are really suffering and, needing the opportunity to connect with things that help them thrive again. And as I'm sure most of you are well aware, and with ongoing news stories, especially in the light of the past year and with the COVID pandemic, we know that there are more and more issues amongst healthcare professionals and physicians in terms of burnout. Some studies reflect that 50% or more of physicians at some point during their career develop significant burnout. Depression, I do a fair amount of graduate medical education work in terms of wellness, and some of the recent studies suggest that 30% or more of residents meet formal criteria for depressive disorder during their training. Suicidal ideation, again, looking at physicians here, but about 6 to 10% of physicians who at some point during their career develop significant suicidal ideation. And then the other themes around moral injury that's experienced, and also the sense of demoralization that sometimes we can develop, particularly in environments where our sense of meaning or purpose is really thwarted. Okay. And then so again, to honor really this year, just the stress that, I think many of us have experienced, our colleagues have, in terms of what the photos capture. So in terms of COVID and also just, demands on our healthcare system, a lot of patient need. And then really honoring too, that I think right this year, the past few years, there's been more attention paid towards structural racism and really how we can make medicine and our culture more inclusive, realizing that there's been patterns of oppression and other challenges that hopefully, we're all becoming more awakened towards, but that in lieu of all these different moving pieces this year, there has been a lot of stress on people. And so this data, again, looking at physicians, but not only in terms of thinking about like as individuals, how is our well-being, how does this impact our experience of what we do? But then if you look at outcomes of the care we provide. So physicians who are struggling more in terms of higher ratings of burnout, symptoms of depression, things like that. Unwell physicians are more likely to order unnecessary care for their patients. They're more likely to commit medical errors or to leave the profession early. And I think we all can imagine, how these things might happen, right? If someone's really burned out, energetically deprived, and they're being challenged to come to work each day and continue to give their all, certainly the clarity and the energy they have is not what we would hope. And then some studies looking specifically at surgeons here, but that patients of burned out physicians faced an increased risk of mortality and longer post-discharge recovery times. So again, just sharing this some of this data to think about, again, why are we spending time focusing on wellness, and why are there all these initiatives for healthcare providers and professionals on well-being? Okay, and then a little bit on the flip side here. So indicators of positive physician wellness or well-being, people experiencing positive relationships, higher sense of meaning at work, better energy, that their patients have higher ratings of satisfaction, ratings of communication with their physicians, and also improved adherence to medication and health behaviors. So bigger picture, just taking these pieces along with us. And then also recognizing that for many of us in medicine, thinking about our self-care, our well-being, and prioritizing that is not always something that, we've either been that we've not developed significantly, or maybe hasn't been a part of our training or medical culture, right? I think for a lot of people in healing professions in healthcare, we tend to adopt more of a selfless attitude, and we really do embrace the concept of how do we put patients first, but we're not always thinking about how we balance that with taking care of ourselves. There has traditionally been quite a stigma on help seeking and being vulnerable, and associated anxiety about what's going to happen with my license application if I have to endorse that I have a mental health condition, for example. And many of us that come into medicine tend to be more perfectionistic. We tend to be hard on ourselves. We tend to put things on our shoulders and just keep moving. And so those can be really amazing qualities for being great physicians, but at the same time, I think also tend to be what leave people more open to developing burnout or struggling more when they're faced with situations that they need to be able to better prioritize or see their own needs simultaneously. And then thinking about our medical culture and impetus to shift culture. So not only in terms of self-care that's been mentioned, but thinking about things like microaggressions that are experienced on a frequent basis, in the concept of systemic racism and how that's affected many people in medicine, and on integrating life and medicine together. So appreciating that, these are some of the reasons why this focus, I think, has a lot of value. Okay. I've touched on most of this, but I just want to come to the last part here, which is the concept that we've invested so much in ourselves as far as our training and becoming physicians, psychologists, really evolved in healthcare, and that there is also the need for us to protect and take care of ourselves to be able to keep going and educate and, kind of bring up the future generations of those in training. And that there is the overlap where wellness isn't kind of an island by itself. And, I think here at UNM, for example, we can consider the overlap with some of the formal offices or other initiatives that we have moving, but really wellness doesn't exist by itself, that it's very tightly connected with the learning environments that we're in, especially when we're talking about training, and also around the topics of diversity, equity, and inclusion. And so I recognize these are big topics we could spend a lot of time on, but I just wanted to take a minute to honor that too. So I mentioned Stanford and their Center for Wellbeing. So they also had conceptualized professional fulfillment in this graph. And so I wanted to share it in terms of some food for thought as we move forward. So again, when we talk about wellness, a lot of times people take away this thought on personal resiliency, right? And if we're helping healthcare professionals become more well, that we need to really help them determine, for themselves as individuals, what do you need to do? How do you shift your mindset? How do you shift your time management? All of those things. And so recognizing here that that is a part of wellness, as the bottom component to the circle highlights, but it is just a part, and that we are very much influenced by the systems that are around us and, that contribute to or detract from our well-being. And so the upper right, the efficiency of practice, is really reflecting that things like EMR utilization or barriers with effective EMR use, having undue administrative burden, other systemic challenges certainly can impact the well-being of people working there. And thus, any spaces that we have for advocacy, or making this more of a systemic piece where we're looking at wellness from a medical profession, from a healthcare system, not just from individual providers. And then the culture of wellness. So a lot of what I mentioned early on, just kind of how what we associate with being a physician or a healthcare professional, and kind of the stigma that may be attached to things like self-care, help seeking, all of those pieces. So hoping that this helps illustrate like the evolution of where we want to continue to push our wellness related efforts. And I know Dr. Towen had mentioned at a recent faculty meeting too, that our goal is to expand some of the formal wellness efforts within our department for faculty and definitely as well for our residents and fellows. And so when we think about that piece, we know that, wellness efforts need to be multifaceted, multidisciplinary, and really target many of the pieces that I've mentioned in terms of cultural barriers, systemic inefficiencies, improving resiliency, meaning engagement for people, and helping people feel like there's conduits for advocacy and change. So really a lot of layers to this. Okay. And sometimes I think with wellness for myself, I can feel like, it's like I'm a pebble in the ocean. There's these ideas of how we can make things better, but then you hit red tape or you hit kind of perceived or real obstacles. And it's just kind of like, I don't know if it's worth doing, but honoring that for each of us, we have these spheres of influence. We can change for ourselves. We can change in our teams and people that we're working with that can have bigger ripple effects within the system. And there's certainly been several examples of this within UNM and throughout, healthcare systems nationally. Okay, so then I just want to spend the last few minutes, and as a segue to Dr. Earl's talk on sleep, looking at personal resiliency. So in part because talking about culture of wellness and practice efficiency certainly could deserve their own hour or more. But when we think about personal resiliency and different pieces that are part to this puzzle, it's more right than self-care and nutrition that sometimes we frequently think about, but there's other layers like for those of us with children or aging parents that we're taking care of, right? How do we juggle all these different parts to our life? Other components like financial counseling. There's just, it's a broader spectrum here. And so I've mentioned some of those here, but also want to look at additional layers of personal resiliency. So for example, some of the studies they've done out looking at physicians and burnout, showing that if physicians spend less than 20% of their time engaged in activities that they find meaningful, they have a much higher rate of burnout. And so I just think these are some of the pieces that may seem somewhat more amorphous, but that, if for ourselves, and again, within like our teams, we can continue to think about how do we focus our efforts towards things that give us meaning or that we get a sense of engagement out of, or that utilize our personal strengths, and how do we kind of recenter ourselves through whatever activity is most helpful, brief mindfulness, self-compassion, that those all have a lot of value. And so I'm going to spend the last couple minutes talking about self-compassion. And this, sometimes people feel like it's a little bit touchy-feely and not as kind of hard science as some things we talk about, but there legitimately is good science about the benefit of practicing self-compassion and realizing that many of us in medicine tend to be good at being self-critical. And that can have a lot of value in terms of learning, pushing ourselves to do our best. But the balance of being able to bring some compassion in can help with resiliency and sustainability. So self-compassion, which is the response to suffering that motivates the desire to help or alleviate the suffering, we can think of in terms of three components, which is the mindfulness, the awareness of the suffering, the recognition of common humanity, that we're all humans, we all make mistakes, we all have some of these same challenges. And that compassion involves this sense of kindness to it. And often we can identify with an experience when we were compassionate, felt compassion towards someone else. And sometimes, identifying with that, we can reflect on how much we direct that energy towards ourselves. So I don't have the specific data here, but I do have resources at the end that share more of the specifics. But looking at self-compassion interventions in healthcare professionals, teaching them, encouraging them to utilize these reflections more often have been connected with many positive outcomes, as are listed here, that are pretty broad, ranging from general resiliency, improvement in relationships, to lower burnout. And this graph, I think, encapsulates nicely some studies that have been done looking at burnout score, which is on the left side there, and then a marker of self-compassion in ways called self-valuation score, which is kind of how people hold themselves, what kind of regard they have for themselves. including their ability to extend compassion. And really, the higher that people rank in their self-valuation, the lower their burnout markers. And the way we think about this happening is, as you can imagine, right, when we hold ourselves in a space of self-criticism or negative thought, it tends to, keep us in a negative pattern of suboptimal performance, and that can all feed into burnout. And so really injecting a little compassion into any of these channels of directionality here can break some of the cycle, or at least slow it. And then this slide being some cool science around. So, for many of us working with people who have a lot of early life trauma or have had significant experiences of shame, we know that that definitely triggers a cascade of experiences that lead to the stress response, like fight, flight, or freeze response, that has negative consequences on our cognitive flexibility and learning. So self-compassion has kind of the opposite outcome, where rather than activating the threat defense system, you see the release of oxytocin and reduction in distress. So again, some of the neurobiological considerations here, but in thinking about, ways that we can engage in even brief exercises of self-compassion. And the one point here of thinking that it doesn't mean we need to take away that layer of our thought process, which is, reflecting on how we improve what we're doing, catching ourselves in terms of ways that we can do better. But that if we can kind of, in a dialectical basis, if we can hold that and a goal towards improving the compassion for ourselves, that there can be good outcomes in many of the measures that we talked about for wellness. So that is the conclusion of my part. Again, kind of tip of the iceberg. There's a lot more here, but really I'm grateful for the opportunity to talk with you all about this. Look forward to more opportunities. And in terms of sleep, which we know is a big pillar of well-being, I'll turn this over to Dr. Earl now. Thank you.
All right, thank you. And unlike Texas football a couple of years ago, I'm actually back, and grateful to be back in the department and to be sharing information with you all about sleep today. And there should be just a title slide displayed. Is that correct? I hope. And you guys can hear me.
David. Okay, good.
Thank you. All right, sorry. Okay. So I'm going to touch on a bit about sleep. One thing that we all have in common is we all sleep. So that's important, obviously, and it is linked to our wellness. I don't have any disclosures related to the material today, and I did put some goals in the announcement for objective reasons. Basically, sleep is kind of multiphasic in what's happening, and there tends to be different observations at different portions of the night, but just reminding you all that we do cycle through different phases of sleep, and each of those phases are important to different physiological processes, with the first half of the night being a little bit more heavily weighted with non-REM sleep, and the latter half of the night a higher occurrence of REM sleep. Lots of Americans suffer from a sleep disorder, and so they are quite common. They're not always identified and treated, but the prevalence is higher than I think a lot of people are aware of. Sleep deprivation, particularly in our society, is also quite common. There are a lot of contributors to that in the Western lifestyle, the amount that we work, artificial light exposure, and some common symptoms of sleep deprivation that are not necessarily specific, but can have a high correlation, or things like fatigue or concentration difficulties, memory problems, and also some of the symptoms that we see and treat in our practices, including things like paranoia, hallucinations, or mood symptoms. Only a night of sleep deprivation can be enough to have an effect. So that shift in PES or being up with the crying child throughout the night, and I'm going to present a little bit of data about some of these things a little bit later, uh, uh, can have an effect. And obviously chronically sleep deprivation can be linked to things. So on the right side of this graphic is things that may happen after a night, or uh, altered immune function. I've got some interesting data I'm going to share about that. There's been a linkage to loss of brain tissue. And then long-term things like risk of cancer associations, difficulty controlling hyperglycemia, and heart disease risk. And touch a little bit on just some different sleep disorders that we see here. And the kind of linkage of wellness with these is if these sleep disorders are present in yourself, a colleague, or a patient, there may need to be something done about them, because it can make a difference in their life quality of life. So obstructive sleep apnea is a very common one. About 1 out of every 7 people is estimated, although that number does vary depending on where you look. We do have a higher prevalence of obesity in this country in particular. So it is quite common. Now, we don't always treat it depending on the severity, but the moderate or severe forms, something should be done about them. Obstructive sleep apnea has been pretty clearly linked in multiple studies to mood symptoms, including depression. And obviously we're attentive to that in our practices, and would want to do something about this if present. And then there's central sleep apnea, which is a little bit more of a different animal, but can be quite prevalent in those who use opioids. Some folks are just more sensitive to central sleep apnea, even at this altitude. Typically, we think a lot about central events, which is the brain pausing to take breaths, as being about 8,300 feet. But the prevalence even here at a mile is quite more common than it is in other parts of the country. So we do sometimes need to do something about that. Somebody may have sleep apnea. Well, a really good thing to do is to stop bang. And usually most of this information is readily available to us in their chart or during their encounter. And a score of 3 is a very high likelihood of sleep apnea, and a score of 5 out of 8 is pretty much almost a certainty of obstructive sleep apnea. And also ad hoc to sleep medicine. I do generate a lot of ad hocs to sleep medicine throughout my experience in psychiatry residency, and now a little bit that I've started practice. This is what we look at over here at the Sleep Center, squiggly lines. Spent a very long year of my life learning what all these different things mean, but just a visual representation. On the bottom half of the image here, these not breathing demarcations, where you see kind of flattening of the respiratory channel lines. And so this is an example of someone that is having what we would call mixed events. There's a bit of a central, but they're predominantly obstructive. Also interesting to us is a lot of what's going on in the brain activity, the EEG. And we have a limited EEG, 6-channel typically, but arousals affects quality of sleep. And we see increased levels of fast activity throughout sleep in people that have anxiety disorders. So there's a lot of potential for interesting research with all the data that we collect, which is a ton of it, 7 nights a week here in the Sleep Center. Excessive daytime sleepiness disorder is a little bit less common, unless it's obstructive sleep apnea or something else that's interrupting sleep and then causing, or insufficient sleep, which a lot of people have, that's causing them to feel sleepy during the day. But narcolepsy is one. There's probably about 600 to 800 narcoleptics in Albuquerque, kind of estimating based off Albuquerque's population and the prevalence of the disorder. So they are around. Not complete zebras, but not every day frequency. And then even rarer condition called idiopathic hypersomnia. Abnormal sleep behavior disorders, however, these have a more common comorbidity with those that we see in psychiatry. And so REM sleep behavior disorder is typically a prodromal finding to an alpha synucleopathy, typically Parkinson's, also Lewy body dementia, as well as multiple system atrophy, along with the loss of sense of smell, can be 10 or more years prodromal, and that's enacting out of dreams. Now, the thing that gets complicated about that is people that have PTSD can also be more active, and we use that as increased muscle activity. Whether it's just phasic muscle activity or tonic muscle activity or actual gross motor movements during REM sleep. And we call that parasomnia overlap disorder. Basically, that's more common in psychiatric patients. They're not necessarily prodromal to have an alpha synucleopathy, which is good. And they are also a little bit harder to treat, who are kind of acting out dreams or having some sort of narrative or motor activity during REM sleep. Sleep talking, pretty common in those that have anxiety spectrum disorders, but it's also just normal. And so it's a person that talks during their sleep. It's not necessarily have to have a diagnosis of any sort. Sleepwalking, a little bit more of a safety issue. About 12 to 20% of kids, usually peak incidence around age 10, will sleepwalk. And then that usually drops off to around 2% of adults. Those of us who are prescribers in the group today should be aware that the Z drugs, zolpidem, azopiclone, and Zalplon, can cause a reprecipitation of sleepwalking. And so there's an FDA warning about that, which means we're responsible for kind of screening for a history of sleepwalking and warning a patient, and plugging that in there. And then nightmare disorder, which are quite, I've only experienced a few in my life. They're quite distressing. I can't imagine what it's like to have nightmares multiple times a month or week. Circadian rhythm disorders, non-24 hours, typically someone that has blindness that also affects their ability to perceive light. Not all blind people have lost the ability to perceive light. And as long as that tract is intact, they still can have a normal circadian rhythm. Shift work disorder, quite common. About a fifth of workers, including those of us in the health community, are shift workers in the United States, and it is not healthy for sleep, and affects overall well-being as well as mood and other effects. And then a delayed sleep phase disorder, which is also about a fifth of people who are just really not programmed to fall asleep before midnight, 2, 3, 4 in the morning. Conversely, they also are programmed to wake up 9, 10, 11 in the morning. Not always conducive to our society. So they usually end up with an insufficient sleep pattern, but it's not really insomnia if we have somebody who has a delayed sleep phase. They're trying to go to sleep at 10:30 because it's when their spouse goes to bed. By the way, women typically are programmed to fall asleep a little bit earlier than men are in general. Interesting science behind those genetics, but we'll still do something to try to help the person get to sleep, even though it's actually during a period of peak alert or increased alertness, because we have these ebbs and flows of alertness as well as sleepiness throughout the 24-hour period, so that they can get enough sleep, because insufficient sleep is more detrimental to health than treating it. And then insomnias have been simplified in sleep medicine to kind of acute and chronic, which is 3 months, and then the symptom frequency needs to be 3 or more times per week. And then sleep-related movement disorders, restless leg syndrome, which is quite prevalent in a lot of the medications that we use in psychiatry, can aggravate this, particularly mirtazapine, as well as other antidepressants, and is relatively easy to treat. We usually like to use alpha delta ligands like pregabalin or gabapentin, as opposed to the dopamine agonist, which have a tendency to cause augmentation, which could be a whole separate talk. Periodic limb movement sleep is basically just kind of kicking the legs during sleep, not necessarily REM. And then bruxism, which is also quite prevalent. Okay. So now I want to spend a few minutes, maybe about 10 minutes, just kind of going through some things I thought were interesting wellness and sleep related evidence. So I wanted to touch a little bit on just topics I thought that may be helpful about sleep, because we all sleep. And plant some seeds there, and then the kind of an update of, well, what's some things that we found in the more recent past that may be of interest. So this is going to touch on a study about sleep loss from frequent awakening being detrimental to mood. And so in this particular study, there were 3 groups that were randomized to a control group who had just normal sleep opportunity, a group of 17 who had to go through the misfortune of being forced awake and were not allowed to sleep more than 280 minutes, and like an hour of that period they had to remain awake. So there was a very difficult to deal with nurse and the study protocol that was forcing these people awake. And then there was a restricted sleep group, and there was 3 nights of this with the mood states bipolar questionnaire, which is a 72 item positive emotion item and negative emotion item questionnaire that was administered each of those days. And basically the findings from that were that if we see that those that had undisturbed sleep, which is the green, were more likely to report positive mood, and less likely on the right side here to report negative mood, because this 72 item questionnaire was 36 positive items and 36 negative items. And so that's why this is being reported this way. Conversely, those with forced awakenings or restricted sleep, which basically is just not allowed to have a full night of sleep, but weren't forced awake at these random times throughout the night, were more likely to have lower reports of positive mood and higher reports of negative mood. So this is a bit of objective. We say that, well, sleep can affect mood. Well, show me some data. Well, this is one of the examples of some data that seems to be nicely done from 2015 that reflects that. This one is quite interesting. This is a study from Finland, 100 children, and this is parents who slept poorly were more likely to report sleep problems in their children, regardless if the child had sleep issues or not. So there was objective measurement of the child's sleep, and the parents saying the child's sleeping poorly. When you check the child with an actigraphy and other things that we will typically do in these types of studies, child's getting enough sleep. And so the take-home point for this particular study is that when you're evaluating possible sleep problems in children, you want to be aware of what the parent sleep quality is, because that could be a confounder to kind of what that reported information is. And so that's a bit of a take-home from that. And so if you're sitting here like, boy, that mom or dad probably has some really bad sleep apnea, and there's like, no neck, or their BMI is really high, or and there's all this narrative about the child having disrupted sleep. Well, the child may or may not. So that's kind of what the point of that study is. Sleep debt. So we have a tendency to abuse sleep here in this country, and it does catch up with us. And we non-REM and REM sleep, and typically the first couple nights of being able to rebound will be non-REM sleep, which is a little bit more important, and then a REM sleep after that. And sleep deprivation has an increased likelihood of creating craving of, and we've heard this before, things that we shouldn't be eating. And so this is an fMRI study that's performed 2017 that basically found that sleep loss can lead to increased hyperreactivity to food cues. And so this was a 39-hour sleep deprivation in 15 subjects who had been able to adequately sleep before, and they're shown in food and non-food images and different areas of the insula in amygdala where activity was found in, suggesting that. I'm kind of skipping over this study quickly because I want to really finish in about 5 minutes so we can have some opportunity for Dr. Sowar or I to answer some questions. So this is big currently, right? Immunity. And so I wanted to touch a little bit because of the pandemic. I knew in vaccination, I wanted to touch a little bit of how sleep can be important to this, because sleep is not just an unconscious period until you start the next day. There's a lot happening. And so there's really a lot happening and lots of interesting bench science and clinical science about this. But I will mention over here in column A is more of neuroendocrine things occurring during sleep. And then this shaded gray area is kind of the 11 p.m. at night to 7 a.m., which is when the majority of people are kind of programmed to sleep with a little bit of variance. But growth hormone release it spikes during sleep, as well as prolactin. Cortisol has a nadir. Epinephrine goes down, norepinephrine goes down. And then in the right column here is different immune functions. And so the dark black line is people who are getting adequate sleep, and the thin line are subjects who are sleep deprived. And what is happening in this is serologic testing in humans between these two groups. And so obviously, I think the big take home point here is this is more data that shows that sleep is important in immune function. Actually, it gets a bit complicated with the increase that norepinephrine helps with increased inflammatory activity during the day, and at night should be attenuated somewhat, and that's how the immune system wants to work. But nonetheless, anything that is altering sleep, or that be breathing or medication or some other process, does have a direct correlation to immune function and immunogenicity. So this study here is related to that. It's a little bit more recent, from 2015. Basically, subjects were given intentionally given drops of rhinovirus infection, healthy subjects, 164 healthy subjects, and followed for 5 days to see who developed, clinical infection. And the image on the right here is those who slept less than 5 hours were more likely to have the objective findings of the rhinovirus cold, whereas those who had longer sleep or more adequate sleep, I want to touch a little bit about longer sleep here in just a moment, were still would develop the active rhinovirus infection, but were less likely. Also, antibody levels were tested 28 days, and there was a difference in serology antibody levels in those that didn't sleep as well. So basically, you get your COVID vaccine, you need to go home and sleep well and not drink alcohol. And so sleep duration. So we have found, interestingly, that we're talking about, insufficient sleep needs to get more sleep, but there's also an issue with too much sleep. So we're thinking about incidence of death. This systematic review found that there's a 12% greater risk of death in people who sleep 5 or less hours per night, and those who sleep greater than 8 or 9 hours per night also have a 30% increased risk compared to those who sleep 7 to 8. The answer is a little bit more complicated than that, because we're all programmed to have a bit different sleep durations based off some interesting genetics that were described in 2017, actually won a Nobel Prize. But long sleepers, staying in bed for 10, 11, 12 hours is not healthy. And so this is a depiction of that. So this is a short sleeper group and the plot of these different studies, and then also the long sleeper group, which is where those risk estimates come from. Okay, and blue light. So I want to touch on this because artificial light is foreign to us, particularly blue screens, and it's about my generation and younger that have really kind of had screens, throughout their life. And so the main finding here in 2000, 4th grade and 7th grade participants in the Massachusetts Childhood Obesity Research Study found that those who even had a small screen, so like a phone or a tablet, not necessarily just a big television in the room, had 20 minutes less sleep per night. And that is significant sleep medicine. In sleep world, 10 minutes is considered clinically significant, so even though it doesn't sound like it. Just touching on medications, I always like to do this. Maybe it's the pharmacist part of me. Their medications have an effect on sleep. sleep quality, and some of the ones that we may think about and some that we don't. So obviously anything that's stimulating, yes, but things like beta blockers, corticosteroids, nicotine replacement products, thyroid supplementation can have an effect. So I always like to include this, could just tell the provider to be mindful of you're trying to target some sort of sleep problem. Is there a med in that medication profile that could be affecting that? Sometimes it's hard to really tell, or they may really need the antidepressant. And some links to sleep disorders and mental health in general. Obviously, alterations in sleep can be, signs of a mood disorder. People that have anxiety, as I was alluding to earlier, typically are found to have increased fast activity in their brain during sleep, or they're just a bit more awake or lighter sleepers. And then alcohol. A lot of people will consume alcohol because they feel like it helps them sleep, but it wreaks havoc on sleep architecture. The brain is kind of like a 24-hour factory. We have day shift workers to do what day shift workers do, and then we have night shift workers to come and do what night shift workers do. And when you're suppressing, this is one of the reasons why medication-induced sleep is not ideal sleep. When you're drugging the night shift workers, they're not doing the things that they're supposed to with the quality that they should. And so some of that washing of toxins out of the brain, which is an important thing that occurs at night, and other circadian processes that actually occur throughout the body are not happening appropriately, then that's why there can be some residual, just feel like didn't sleep well, and can have some mood correlates. So really encourage the less alcohol, obviously, they consume, the better, but it is very unfriendly to sleep. There are a lot of other medical problems. So if you're wearing your doctor hat, sleeping, I would just say that dementing illnesses are one where there's a lot of disruption in the circadian phase, which is why we had the recommendations that we do about the Clear Minds protocol. I'll skip on treatments. That would be another talk. And I always need to, I had lost a very dear family member of mine who as a shift worker at a dairy plant and fell asleep on his way to work, had the cruise control on, which you definitely do not want to do when driving in the middle of the night, and went straight off of the highway. And that was very hurtful to me a number of years ago. And so this is something that I think is taken lightly and has a lot of impact in the majority of accidents occur between midnight and 6 are believed to be linked to this, because it is when we were programmed to be asleep. And the big finale is that we should be getting that 7 to 9 hours as adults. It's a little longer for teens. Okay. So rush through that. Left us about 7 minutes. Thank you for participating. And Dr. Sowar and I are happy to take any questions.
Thank you, Dr. Earl, and thank you, Dr. Sowar, for a tremendous presentation. We can start. Dr. Delmore has a question in the chat for you there, Dr. Earl.
Question in chat.
Yeah.
Okay.
There's any difference in sleep between SSRIs and SNRIs?
So there are 5 neurotransmitters that we love to play with in psychiatry. They're all wake promoting. Okay. So serotonin is one, and they're all in the brainstem, locus coeruleus. Dopamine is one. So anything that's potentiating dopamine can have a tendency to increase wakefulness. Histamine is one. That's one of the reasons antihistamines are quite effective. Norepinephrine is also one, and orexin is one, which we don't really monkey with too much, although we may start doing that because orexin antagonists are quite effective for insomnia treatment, and they're really safe, including in older people that have fall risk, which if you have data that says this is okay to use in an older person with fall risk, that is going to be a really good drug, and they do. So anyway, so we're potentiating those a lot of times in treatment of mood disorders. So they can definitely be linked to both insomnia and increased restlessness in the body, typically restless leg. When restless leg during night, we call it periodic limb movements of sleep. So yes, that's why typically we want to dose a lot of them in the morning. Now, if it has an antihistaminergic effect, like Paxil, for example, can be a bit sedating, well, and then at night. So that, typically if for some reason the person's having a paradoxical effect and they feel like the Prozac or whatever it is makes them sleepy, then when we tell them at night, because we don't want them falling asleep driving, But for the vast majority of people, these agents, the further away from the sleep period, the better. In the potency of SSRIs versus SNRIs actually could be a little bit more problematic, but there's not a lot of real clear data on that. It's mostly association stuff and reported in the trials for approval.
Any other questions people have, go ahead and put them in the chat. Or turn on your video. I guess I have.
Go ahead.
Yeah, I have a question, Dr. Sowar. As we work with younger and younger trainees, I know that I know that anxiety about the climate is continuing to grow, particularly in younger generations. And so I'm wondering if that's ever talked about in the wellness world, because it's so all around us and so in the news and facing us all the time, and such a challenge to actually think about staying well when our earth is hurting.
Yeah, definitely. No, I think it's, yeah, it doesn't, I think certainly something that comes up in circles focused on, yeah, like how we promote well-being, or really how we attend to some of the different influences and stressors. And I mean, it's kind of, I realize, complex consideration too, that, you know, many of us are probably dealing with day to day, but yeah, I mean, I think the goal is just to improve awareness about it and hopefully reduce some of the stigma or, you know, barriers that have existed more so historically to people talking about it or kind of supporting one another through it. Thank you, Dr. Delmore. Yeah, and certainly in terms of, yeah, our world and climate psychiatry and such, that, yeah, it's that balance, I think, of how we attend to and how we try to, you know, take care of ourselves in the midst of all these different circumstances around us that can produce a lot of stress. But yeah, it's something that comes up a lot, and I would love to hear feedback from other people on their ideas how we can support our upcoming training generations too. Thanks, Dr. Delmore, for sharing that.
Any other questions out there? Lillian shared in the chat that she uses a phone application called Twilight that automatically starts to filter out blue light once the sunset begins in your local area. So that's pretty cool.
Getting rid of the blue light's helpful. You know, ophthalmologists are pretty passionate about this. There's some retinal effects from blue light that our parents and onward didn't have as much exposure to. So it's more problematic than we think, but it's just the light, the brightness in general still can have the effect of suppressing melatonin release, which is the predominant driver of sleep. Now, melatonin is quite helpful, particularly in older people, because their brain makes less of it. I have a nice image that can show where there's decreases in the amount of melatonin that's secreted throughout time. Now, part of that's supposed to be because just part of the aging, but some folks do need to take melatonin about 4 hours before desired effect. And so it's not necessarily a failure if someone's taking at bedtime and, well, it doesn't work. Well, they may already be asleep by the time it's kind of kicking in for them. So sometimes that's a good tool to pull out for if wanting to use that agent.
Any last suggestions you all have that faculty can utilize to support our learners and our learners' sleep, which hopefully would also promote their wellness? Do you have any tips or tricks for us?
Well, I try to remind them that one of the things after studying that really helps is to get a solid night of sleep after that, because that memory consolidation predominantly occurring during non-REM 3 needs to happen. So it's a real waste of time to spend hours studying and then sleep poorly, or go home and consume alcohol because, oh, I'm so stressed because I've been studying all day, because it completely wrecks that system, and the encoding of memory is essentially trash for the night. So they recall less content. That usually really matters because learners are taking exams a lot. So they usually can kind of appreciate the importance of that. So yeah, you hear don't cram, it's not good for you, but why not cram? It's because you just don't get to encode the memory very well. So that sometimes I think sticks. I mean, I tell learners that. Of course, I say lots of things, and so I don't, but I try. But I would suggest that. Also, exercise is good for this cardiovascular exercise, as effective as an antidepressant, we all know this, is really good at helping with the washing of metabolic waste. The brain, 20% of what we consume goes to powering our brain. It's a very metabolically active organ, and so it generates a lot of metabolic waste. And obviously that piece, exercise is good. Well, why is it good? Well, that's another one of the reasons.
Right. Dr. Sowar, Dr. Earl, thank you for fantastic presentation. Everybody out there, have a very well and restful weekend, and good to see everybody.